morning, senior colleagues. Good morning, interns and ITs. I'm Pharmacist Priscilla, a moderator for our usual Monday's clinical units presentation. Here we have our timekeeper, Fanfidozi. We'll have 8 minutes for your presentation, after which we'll ask a few questions. So we'll start with our first presenter, Anna, on pharmacology, pharmacodynamics, and pharmacokinetics, and mechanism of action for pharmaceutics. Anna, you're up.
Good morning, unit head. Good morning, senior colleagues. Good morning, interns and my fellow IT students. My name is Musa Hannah Enyojo. I'm here to give a presentation on the pharmacokinetics, pharmacodynamics, and mechanism of action of analgesic drugs. So the presentation outline as follows: introduction to pain and analgesic, classification of analgesics, pharmacodynamic is pharmacokinetic and mechanism of action. So I'll be starting with what is pain. Pain can be defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. It can be acute, chronic, or neuropathic, and it can be caused by nerve damage or dysfunction. And what are analgesic? Analgesic can be defined as drugs that are used to relieve pain without loss of consciousness. They act at different parts in the pain pathway. Example, the pain pathway, which are transduction, transmission, perception, and modulation, to reduce the sensation of pain. So the main classes of analgesic are non-opioid analgesic, opioid analgesic, and adjuvant analgesic. The non-opioid analgesic, they act mainly by inhibiting prostaglandin synthesis and are used for mild to moderate pain, fever, and inflammation. Each we have the NSAIDs, which is the non-steroidal anti-inflammatory drugs. We have the ibuprofen, diclofenac, etc. Then we have the opioid analgesic. Opioid analgesic, they act on the CNS by binding to the opioid receptor, which are the mu kappa delta receptors. They are located in the brain and the spinal cord, and they are used for moderate to severe pains like post-trauma pains and like post-traumal pains and post-surgical pains, etc. Then we have the adjuvant analgesic. The adjuvant analgesic are drugs and are not primarily designed receptors, which are the mu kappa delta receptors, which inhibit the transmission of pain impulses and modify the emotional responses to pain. And then we have the adjuvant analgesic, such as antidepressants, anticonvulsants, which enhance pain relief by modulating neurotransmitters involved in pain signaling. So for the pharmacokinetic of this analgesic, the pharmacokinetic of analgesic involves four main processes, which are the absorption, distribution, metabolism, and excretion. So analgesics are well absorbed when administered orally, rectally, or parenterally. Lipid-soluble drugs, especially opioids, easily cross the blood-brain barrier to reach their sites of action in the central nervous system. They are widely distributed in the body tissues and they bind mainly to the plasma proteins. Then the metabolism occurs mainly in the liver, where most analgesics convert active metabolites to inactive metabolites. And then the excretion is mainly through the liver. And then for the general mechanism of action for these classes of analgesic, non-opioid analgesic like NSAIDs and paracetamol, they inhibit the enzyme cyclooxygenase, that's COX1 and COX2, reducing the synthesis of prostaglandins that synthesize pain receptors. And then we have the opioid analgesic, which bind to the opioid receptors, which are the mu kappa delta receptors in the CNS, leading to the inhibition of neurotransmitter release, which prevents pain signal transduction. And then we have the last one, which is the adjuvant analgesic, which work by enhancing the effects of primary analgesic through various mechanisms, such as increasing the serotonin and norepinephrine levels. Thank you.
Thank you for your presentation, Anne. So are there any questions, contributions? Will you answer them?
Okay. Before we ask questions, Can anyone, in 2 sentences, summarize what Hannah just told us? In 2 sentences.
So essentially, ma'am, good morning everyone. So essentially,
Can you tell us your name?
my name is Paul Kingsley Choneka. So essentially, she talked about analgesics. You know, analgesics as classes of drugs that has to do with pain modulation, relieving of pain. Now, essentially, what she talked about is the fact that pain comes in different ways. We have the nociceptors and the neuropathic pain. So there are different classes of pain, and there are different classes of drugs that act on those different classes of pain. So essentially, she talked about how nociceptors are affected and how drugs can modulate the pain at the nociceptors. Then she also talked about drugs like gabapentin that helps in the modulation of neuropathic pain.
When you know it's more than 2 sentences, you actually achieve what I wanted. She mentioned amitriptyline. I don't know if that sounds new. How can amitriptyline be an analgesic? Or from what she just explained now. So do we understand? Okay. Another thing, because we're also here to train you on your presentation skills, aside oral presentations, your slides. Hannah, your slides are not so good. It's unfortunate we can't project our slides here because it's a unique presentation. But I think we'll work towards getting our own projector here so that we could see what we're saying. Look at how you present, you prepare your slide. The font size are different. Some are even in bold. You bolded some slides, while some do not even have this thing, headings. And there's no conclusion. You started, you gave us an outline. I don't know if you guys observed. You gave us an outline, but in the long run, there's no conclusion. So please, we're preparing you guys on how to do PowerPoint presentation and oral presentation better. Thank you. Any question for her? Question?
They didn't tell us the role of amitriptyline in pain modulation. The role of amitriptyline in pain modulation.
Amitriptyline is like adjuvant analgesic. They don't just like help in relieving pain, but they help in like they help other analgesics like to reduce the pain without causing loss of consciousness.
Without causing loss of consciousness. Amitriptyline is not drug, is it not sedative? Amitriptyline.
What class of drug is amitriptyline?
No, on its own.
On its own.
Before being an adjuvant, what was its main class? What is amitriptyline used for?
It's used for relieving.
Please speak up, speak up.
It's used for relieving pain.
You mentioned it now. You mentioned it. Go back to your slide. When you talk about analgesic, adjuvant analgesic, what did you say? You mentioned it. Example what?
Say e.g.
Example what?
Antidepressant.
So what is amitriptyline?
It's an antidepressant.
When you were preparing this slide, did you wonder why amitriptyline is an analgesic when it's already an antidepressant? Did you? Okay. Any question?
Do you understand that how amitriptyline came into that picture? Let's try. So let's jam our hands together.
So I have a question to ask. Okay. It's just paracetamol. I saw when I was preparing the slide that it doesn't help in reducing inflammation like other NSAIDs. So I want to know why.
Okay. Who's ready to answer this question? My resident, can you answer her question before I come in? Intern, you want to answer?
I think that paracetamol is not an NSAID. That is a non-steroidal anti-inflammatory
Why?
drug. What was your question again? That it does not.
She said, why is it that paracetamol does not have anti-inflammatory effect, but ibuprofen has anti-inflammatory effect, isn't it?
Yes.
So in a nutshell, you're saying paracetamol is anti-pyretic.
Yes.
It does not have anti-inflammatory. So why?
It
I
does
also
not
have
prostaglandin. It does not post-antihistamine.
It's the mechanism of action. Can you tell us the mechanism of action? It's the mechanism of action of paracetamol. Paracetamol does not, its pathway does not COX. If you look at the NSAID, they work on COX-1 and COX-2. Paracetamol does not act on that pathway. So it does not have anti-inflammatory effect. It only have antipyretic and analgesic effect. Unlike the NSAID have little antipyretic effect, but more anti-inflammatory and analgesic effect. Do you understand? So for someone, what it means is that when you're running temperature, paracetamol, you benefit from paracetamol better. When you have maybe an inflammation, like a swelling, paracetamol will not do anything. But NSAIDs like ibuprofen, aceclofenac that we have will do better. But you also see a situation whereby ibuprofen and paracetamol is being added, or aceclofenac and paracetamol is being added. It's because you want to have both anti-inflammatory and antipyretic effect at that particular time or that particular condition. Did we answer you?
Yes.
Thank you. For Priscilla.
Okay. Our second presenter is going to tell us on the pharmacodynamics, pharmacokinetics, and mechanism of action of antihypertensives, specifically the angiotensin receptor blockers and the angiotensin converting enzyme inhibitors. That's by Ayodeji. Okay. So,
AKA AY. Round of applause for me.
Good morning, United. Good morning, my senior colleagues and our interns and my fellow IT students. So I'll be presenting on, my name is Opadi Refit already, and I'll be presenting on pharmacodynamics, pharmacokinetics, and mechanism of action of antihypertensives, emphasizing on ARB and ACE inhibitors, which we all know as angiotensin receptor blockers and angiotensin converting enzymes inhibitors. So basically we have to understand what hypertension means. We can just say hypertension is like is defined as a blood pressure of 140/90 mm Hg. So, and it may be higher more than that actually. Antihypertensives basically are drugs that we take that controls our blood pressure and prevents complications such as stroke, heart failure, kidney disease. So ACE inhibitors and ARB are the first line drugs targeting the renin angiotensin aldosterone system, which we know as RAS, RAAS. So I have the renin angiotensin aldosterone system overview, whereby the RAS cascade begins with when renal cells release renin, then it converts angiotensin 1 to angiotensin 2 with angiotensin converting enzymes. So now talking about angiotensin converting enzymes inhibitors, they reduce the formation, they block the conversion of angiotensin 1 to angiotensin 2. So now the mechanism of action of ACE inhibitors, during this process of blocking, they reduce the vasoconstriction and then inhibition of increase in plaquenil levels and enhance vasodilation. So they have their therapeutic effect, which lowers the blood pressure, reduce cardiac preload and afterload. So ACE inhibitors pharmacokinetics, they are administered orally and then they are well absorbed in the body. So their bioavailability varies. Like examples of ACE inhibitors is lisinopril, where it has, I think, 25% bioavailability. So they have half-life and dosing. Lisinopril half-life is 12 hours. Once you should be taking once daily basically, and enalapril, captopril, they also have their own dosing and so on. So ACE inhibitors pharmacodynamics and the safety, they produce vasodilation, lower systemic vascular resistance, and decrease cardiac workload. So they also have their clinical benefits, which include reduction of proteinuria and slowing of progression of diabetic nephropathy. So we also have, first dose hypotension. When you take ACE inhibitors now, the first dose is likely to like the side effects may come out as maybe example hypertension. So, and we also have the rare one, angioedema. Now, talking on the angiotensin receptor blockers mechanism of action, they are blockers that antagonize angiotensin 2 type 1 receptors, preventing angiotensin 2 from eliciting vasoconstriction. So, they do not increase BRAF kidney levels like the ACE inhibitors, but they reduce the risk of cough and make them suitable alternative for patients. Now, talking about the pharmacokinetics of angiotensin 2 receptor blockers, they are taken orally and exhibit good bioavailability, which with hepatic metabolism, producing active metabolites. When we're talking about hepatic, like maybe a drug is in an active state and then it's metabolized to an active form also.
Okay, continue.
So distribution is wide and is contradicted in pregnancy due to potential fetal harm. Then the half-life and dosing. Examples of ARV is losartan, valsartan, temsartan, and they all have their dosing. Should be once daily also. So pharmacodynamics and safety of angiotensin receptor blockers. They produce sustained antihypertensives and their clinical advantage, they include likelihood of cough, clinical application and service observation. So during my service here at University of Abuja Teaching Hospital, nisinopril and losartan and temsartan are mostly prescribed and dispensed to all these hypertensive patients. So, pharmacist's role, we have to advise patients to take the medications same time each day. Then I have my conclusions. ACE inhibitors and ARV remain cornerstone therapies in hypertension management, offering blood pressure control and organ protection through complementary mechanisms. And I have my references here.
I'm really interested about a slide presentation. Where he wowed me, he even brought his experience in NHIS. For me, I think I've achieved something. He could relate theory to practical. Sincerely, I'm fulfilled, Ayo. I hope more people will get this from Ayo. With this, I will rate our resident that would have done well. Sincerely. If you go back to school, your pharmacology, I'm telling you, you're going to ace your pharmacology. But notwithstanding, we still have some, when someone is good, we want someone to be excellent, right? So there are some things we need to correct. And Priscilla, over to you. Sorry, I had to.
I know you're very excited. Yes. I would appreciate him for a job well done. It shows that you know what you're doing.
Yes.
I was actually following your slide, but you were not reading through your slides.
Yes.
You were more of explaining, which is good. But
Yes.
then sometimes you may be good. They say when they give you certificate in school, they give you certificate based on what? Character and learning. The learning aspect is excellent. The character with which you were presenting was not good.
Yes.
You were being too shabby and ras. So you have to watch your use of English and the way you were just like this kind of I don't care, it doesn't concern me. You're presenting, you need to be coordinated, compose. Your composure is not good at all. You have to work on that. You try to compose yourself when you're presenting and mind the use of your language. You were saying something like that, whatever. I mean, what was the other one said?
Like the way you said,
hypertensive people or hypertension.
I think something like that. So you are the one presenting, you are telling us you shouldn't be thinking something like that. So you have to work on that aspect so that it doesn't bring you down. Some, no matter what you present, they'll just get angry with that particular word and they'll just feel you at the end of everything. They'll be thinking that you've done a very good job. So put at the back of your mind and work on it. But you did a very good job. So a round of applause for
Okay, sorry, we need to ask you a question. That's why I said, okay, I allow you to talk because of shadowed your this thing. I want you to tell us what angioedema is. Because, yes, just take your time, relax, young man, relax. Then I have two questions for you. The first one is tell us what angioedema is, because you said when you take the first dose of lisinopril, there's a possibility you come down with cough. Oh, sorry, hypertension. Cough. Yeah, he didn't mention. Okay. You said hypotension. I think because I know the primary, that's why. So you didn't mention cough. You understand?
Yes.
Then secondly, you said hepatic metabolism. You're trying to tell us what it means, that when you take an active drug to convert it to an active something. Okay? So I want you to like elaborate on that, expatiate. Do you understand? Because I don't know what is take-home message. Did anyone get any take-home message? I don't want Kingsley. Faisal, what's your take-home message from IELTS presentation? You're yet to. Faisal, what is your take-home message from IELTS presentation? Charles, what is your take-home message from IELTS presentation?
He said it's not pray. It doesn't should mostly be taken the
I
same
can't
time.
hear you.
He said the sin of prayer, it doesn't should be taken the same time every day.
But what do you mean by the same time?
Like if you take it by 7 a.m. today, it should be around 7 a.m. tomorrow.
What if I overslept and I woke up around 10 a.m. Can I still take it, or I'll wait till the following day? Since you said I should take it at the same time.
You can still take it, but it should be within the range of 12
But I
hours.
overslept. So what should I do? Should I leave the drug and leave it the following day to take it by 7 a.m.? I woke up 10 a.m. Who can answer that? No, not Kingsley. Kima,
But you can take the drug.
volume please.
I said you can take the drug.
Okay, why did I take it? He said I should take it 7 a.m. every day.
Okay, for what he said, the lecturer said, I think the drug is meant to be OD. That's once times daily. So and it's 24 hours. So at the time when you take it, if you overslept and you take it at 10 a.m., you just add another 24 hours so that it can be more effective and metabolize.
You said something again I want to ask Mr. Von. You said like spirit prayer is once daily. And now, yes. Okay, do you have a contrary opinion? Okay, but you said from his presentation. So if the drug you're taking is 7 a.m., but this particular day you overslept and you woke up 10 a.m., you asked me to still go ahead and take it. Will I now continue 7 a.m. or 10 a.m.? What should I do?
Since the day has been interrupted, I think the next day you're going to take is supposed to be the next 10 a.m., not the 7 a.m.
Okay, but did you tell us about, because there's something you made mention. You boldly said half-life, we have half-life, they have dosage. So what is half-life? We're coming back to you. What is half-life? What do you mean by like you have 12-hourly dosing or 24-hour dosing? Can you expatiate? So 3 questions. Thank you. The remaining 2, who did I ask? Hannah and Sabira. I'll ask you questions later.
Okay, the first question you said,
What's angioedema?
angioedema is an allergic condition. It's an allergic condition actually. That maybe swelling under the skin or throat or
Angioedema, is it swelling under the skin?
edema.
Angioedema.
The edema means skin. It may be under the skin, throat.
Edema
or
means skin.
like skin related.
Edema. Hannah, what is edema? What is edema?
Edema.
If you don't know, pass to Sabi. Say pass.
Edema is like swelling
Okay.
the skin.
Swelling where?
Swelling.
Under the skin.
Under the skin. Sabi, do you agree?
Yes, ma'am. Edema is just
Can you stand up? I can't see.
edema is just swelling, accumulation of fluids. It can be anywhere. It does not have to be
Under
under
the skin. That's what I want to. Not under the skin. So angioedema, where does it occur?
Yeah, for maybe on the lips.
Angioedema.
So I'll go on the lips.
Okay.
I have like reference.
For Priscilla and Fafidos, do we agree?
On the lips.
Yes.
As relates to what you're talking about now, antihypertensives or hypertension, where does it occur? You're saying lips.
Who can help you? But you're very sure that your cause on the lips.
No.
It's
It's just like swelling.
Continue.
It's not mentioned the legs, so you are running to
Yes,
the
the
lips.
ankles. Yes,
Those are the
extreme.
basic
You understand?
places,
Yes.
extremities.
Then you asked about hepatic. So hepatic is when we hear the word hepatic, it means something related to liver.
Okay, I want to correct myself. I think Ayo is very correct. Angioedema actually occurs the lips, the throat, as you said. I want to correct myself. So Ayo is actually right. I think we are the ones that are wrong.
But in case of hyper, it can occur based on allergies,
Yes,
right?
but the question is what is
Okay.
angioedema? Yes. So we generalized it, we didn't specify, narrow it down to hypertension. So continue.
Okay, so hepatic is related to liver, and when we are talking about this hepatic conversion, it means like a prodrug in active state now being metabolized to an active form. So
Prodrug. But when we're talking, you say active drug metabolized.
no, I said inactive. I was
Inactive.
inactive.
Okay.
I was, so maybe I didn't pronounce it. So
Okay.
inactive
Okay.
to an
Okay,
active
so the
form.
last one, when you talked
I
about
was talking about the
when you talked about half-life, you said half-life of dosing 12 hours. They have a half-life of 12 hours, so once daily.
yes, ma'am. So I didn't get the question very well.
So Ima said that since it's once daily,
Yes.
that I can still continue with my medication by 10 a.m. Then tomorrow I'll just continue 10 a.m. I don't know why I can't go back to 7 a.m. again, which is my routine. It was just that particular day that I slept up. And I asked what is half-life.
Half-life is just like the hours take
Time.
the time take a drug to metabolize. So lisinopril actually from my own research it says 25% availability, which lisinopril is basically 12 hours once a day. And maybe when you take it now, after metabolizing for let's say the 12 hours has done, then maybe you slept over or you were unable to take the drug that same time. Maybe you do take it 7 a.m. You can still take it around 10 a.m., 12 a.m. But ensure that 12 a.m. you can't again 12 hours. So that means you've changed the time that you do take it.
Do we agree for Priscilla? For those, because I want to understand. Yeah, Paul.
Good morning, everyone. First things first now, we're speaking about his medication, saying the frequency of taking the drugs. And if by any chance you miss a dose, the important thing is to take it as soon as possible, especially when the medication is like a once daily medication. What you have to put in mind is that you don't want to miss your medication for that day. So as soon as possible, when you get up, take the medication. And then next time you try not to miss it. And then you can try not to miss your medication by setting time. The reason why you fix a particular time, say 7 a.m. or 10 a.m., is so that you remember to take the medication every day. So you try your
I think you didn't
possible time.
answer the question. The question is saying, yes, you didn't answer the question. The question is saying, now he took by 10 a.m. Should he continue subsequently 10 a.m. or go back to 7 a.m.?
No, you continue with the previous time, the 7 a.m. that you have always taken the
You
drug.
just said it's 12 hours.
No, no,
and
no.
this patient took more than, it's even 24 hours. If you look at it, the daily dose is 24 hours. You understand? And you're saying it's 12 hours, so it has metabolized. It's just the remaining, it has attained the steady plasma concentration already. So it's declining, but still that effect is there before. So you just continue to 7 a.m. Thank you very much, Priscilla. Over to you.
Okay. Thank you very much for good presentation. I hope we are all getting something from it. Like I told you, you don't have to present on all this, but as your colleague presents, that knowledge has been added to yours. That's the essence of everything we're doing here. So don't take it lightly that I'm not the one presenting. Pay attention. And
I have something to say about that. All the ACE, the first thing to look out for is cough. For any patient that is on an ACE inhibitor.
you wrote it, but you didn't say it.
No, he didn't even, okay, he
You
didn't
wrote
mention
it.
it.
You mentioned it, that it's not
First thing to
a
look out for is
When I
cough.
was
Right
talking
cough.
about
And again, I was going to ask, can we Because you said something that most of the antihypertensive that are being prescribed, you said losartan and lisinopril. Well, I tend to disagree with you because losartan is not as prescribed as telmisartan. I felt telmisartan should come the first, even though I know the first example from your book was telmisartan, but practically it's telmisartan. But I want to ask the question again: can we take telmisartan and lisinopril at the same time? Okay, why?
Because telmisartan and lisinopril are the same, like they actually block the renin-angiotensin-aldosterone system. So it's not advisable to take them together or to even take them maybe 1 hour before.
It's just start for me because if a 400 pharmacy student and you answer them. Okay, 300
are starting now. No, you are doing Abuja.
You try.
After this presentation, you have promoted yourself to 400.
400 level.
You are qualified. You have tried. Everybody has done well. The next presenter is going to tell us on the pharmacodynamics, pharmacokinetics, and mechanism of action of calcium channel blockers and diuretics. That is Kingsley.
Okay, good morning to my interns, good morning to my senior colleagues, the interns and my fellow colleagues. My name is Paul Kingsley, and I will be speaking on the pharmacodynamics, pharmacokinetics, and mechanism of action of calcium channel blockers and diuretics. But first, what are calcium channel blockers and diuretics? They are classes of antihypertensives. Antihypertensives are classes of drugs that are used in the control and management of hypertension. There are also comorbidities like angina and arrhythmia that we can also use these drugs to cure. So what are calcium channel blockers? Calcium channel blockers are medications that inhibit the L-type channel, the L-type voltage-gated calcium channels in the cardiac and smooth muscles. So what are the L-type voltage-gated calcium channels? They are high voltage channels that allow the passage of calcium ions into the cell, and the presence of calcium in the cell leads to contraction. So calcium channel blockers are usually prescribed to inhibit the L-type voltage-gated calcium channels in the cardiac and smooth muscle, thereby decreasing intracellular calcium ion, and which then leads to the decrease in the contraction of the cardiac and smooth muscles. So we have two classes. So the effect depends on two classes. We have the dihydropyridines and the non-dihydropyridines. Now the dihydropyridines, example we have here, like our amlodipine and ifedipine. Those are drugs that affect mainly the smooth muscles of the blood vessels. While the non-dihydropyridines, like verapamil, they affect both the smooth muscles of the heart and the smooth muscles of the blood vessels. So we have the dihydropyridines. They have strong vasodilation, decreased blood pressure, and reflex tachycardia. So they achieve this effect by causing the relaxation of the smooth muscles of the blood vessels, thereby reducing blood pressure. Then we have the non-dihydropyridines. They also provide an effect of vasodilation, although not as much as the dihydropyridines. And they also have the effect of decreasing heart rates and decrease AV nodal conduction. So AV nodal conduction is essentially atrioventricular nodal conduction that has to deal with the rhythmic exchange of blood from the arterioles to the ventricles. So the decreased AV nodal conduction helps in smoothing the rhythm of the blood pumping in and out of the heart, thereby also reducing blood pressure. Then we also have increased contractility. So the net effect of calcium channel blockers, they are antihypertensives, anti-anginal, and anti-arrhythmic. So angina is a condition whereby angina. Okay. So angina is essentially a condition whereby there is reduced blood flow into the heart, and this causes pain. While arrhythmias are irregular heartbeats. It can be a condition of the heart beating too fast or the heart beating too slow. So we have the pharmacokinetics of calcium channel blockers. We have the absorption. So for calcium channel blockers, the absorption it's usually absorbed orally, and it undergoes first pass metabolism, which then leads to the reduction in the bioavailability of the drug. So we have the bioavailability. Now the bioavailability is variable. For drugs like amlodipine, they have higher bioavailability than nifedipine and verapamil. So we have the distribution. The distribution is highly protein bound. This means that it is usually carried in the blood, and when it acts on the smooth muscles of the blood vessels, it thereby reduces the blood pressure. So we have the metabolism. Metabolism, that is essentially how the drug is being broken down after its effect has been shown and how it is being excreted. So the metabolism is carried out by the cytochrome P450 enzyme, which breaks down, for example, in this case, the amlodipine into its metabolites, and it is then excreted renally. So we have the half-life. Amlodipine half-life is usually 30 to 50 hours long. Verapamil and diltiazem is usually 3 to 7 hours, which means it's shorter. So amlodipine comes in different concentrations. We have amlodipine 5 mg, amlodipine 10 mg. Like we have here in NHIS, there are several concentrations of amlodipine and also combination of amlodipine with other antihypertensive drugs. So depending on the severity or depending on the effect you want to achieve in terms of reducing the blood pressure, it is usually reduced. So we have diuretics. So diuretics are also called water pills. Diuretics, they promote the renal excretion of sodium and water, leading to decreased blood volume, which then leads to decreased preload and cardiac output. So we have the different classes, and the three major classes include thiazides, e.g. hydrochlorothiazide. So hydrochlorothiazide inhibits sodium and chlorine sympathia in distal convoluted tubule. Then we have the loop diuretics, e.g. furosemide, which inhibits the sodium, potassium, and chlorine sympathia in thick ascending loop of Helm. Then we have the potassium sparing spironolactone, e.g. spironolactone, which inhibits sodium channels or aldosterone receptor in collecting drugs. So we have the pharmacodynamics. It is usually absorbed orally, except mannitol, which is usually IV, due to its need. It's usually used in emergency. So we have the distribution. So the distribution is also variable, and loop diuretics are widely distributed. So we also have the metabolism, and metabolism usually occurs in the liver, and the excretion is mainly renal. So we have the onset and duration. For loop diuretics, they are rapid and short acting, while thiazides have slower onset or longer duration, and spironolactone have delayed onset, usually days and long lasting. So the mechanism of action of loop diuretics. Loop diuretics, they block the sodium, potassium, and chlorine transporter, leading to decreased sodium, potassium, and chlorine reabsorption, leading to powerful diuresis. While the thiazides block the sodium and chlorine transporter in distal tubule, leading to moderate diuresis and vasodilatory effects. While the potassium sparing, which is spironolactone, is an aldosterone antagonist, leading to decreased sodium reabsorption and decreased potassium excretion. Then we have the amiloride and triantherine, which block the NR channels, leading to sodium reabsorption and decreased potassium excretion. Thank you.
Thank you very much for your presentation. So I think you did well, you did justice to your topic, but you didn't have a conclusion. So and you're free to also recommend recommendations. Okay, you think NHIS should start stocking the drugs that you feel are more important, you think we should stop dispensing this one, you think we should do this, you think we should do that. Maybe you'll do another presentation before you leave, right? With your concrete reason.
Yes.
You do your recommendations for us so that we can learn from you as well, just as you learned from us.
Okay, so are there any questions, contributions? And you didn't conclude your topic.
The thing is, as I said, so far I've not seen anyone that have beat.
I don't want to make that feedback.
No. I'm a very practical person. I actually was expecting much from Kingsley. Sincerely, I was expecting much from you. But you tried, but you didn't meet my expectations. So the primary goal is for us to see how we can, like if you go back to school now and they ask what's the mechanism of action of spironolactone, can you tell us? Did he mention it?
Yes, ma'am.
You did?
Yes, ma'am.
Oh, okay. So, okay. In your statement when you were talking, you said antihypertensives cure hypertension.
No, I said in the management and control.
No, you mentioned cure. I had cure because immediately I noted that and I put comma. I had cure. So I want to ask, do antihypertensive cure hypertension? If they cure, then
That means it's a mistake.
yes. Okay. I just want to correct that. Do we agree? Do antihypertensive cure? Okay. Then I want you to tell us what is first class metabolism. You mentioned that. Then I also want to ask why you said that a lot of amlodipines are being combined with other medications. Why? Because the way you talked about amlodipine, for me it's fantastic. Only amlodipine can do the job. So why do I need to combine it with others? Then lastly, there's a particular diuretic that you didn't mention, clothalidone. Where does it belong? Because we want to, relate these things to what we'll be learning. You mentioned spironolactone, that's a good diuretic. You mentioned ethiazide. You mentioned indapamide. You didn't also mention indapamide. And we'll have indapamide here. Where do these diuretics belong? Thank you.
Okay, so first pass metabolism is essentially when drugs are usually taken orally, when it goes through the GI tract and it wants to be converted to systemic circulation. It is usually reduced whereby the liver acts on the drugs, breaking those drugs down and reducing the bioavailability.
Do we agree? Do we agree? Hannah, do you agree? Do you agree with his explanation? Also, Faisal, you were very close. Do you agree? You do not remember? Sad. Faisal.
I do.
You agree? Okay, why?
Explain your first part of metabolism.
Is that what it is?
I think that's what it is.
Yes, is that what it is? Do you agree that
Yes.
It's actually correct? Continue. I just want to know if you guys are following.
So can I get the second question?
Yes. The second one, why is amlodipine combined with other medications?
Okay, during my stay in NHIS, I also noticed that there are combinations of drugs.
It's your first week, not the first day of the last week. So we've not released you yet. You're saying during your stay in NHIS, you're still in NHIS.
Okay, there are drugs that are usually combined. Now, we know that antihypertensive is a very broad class, and each class have different mechanisms of action. There are some that, like the diuretics, which reduce the blood volume. There are some like the diuretics which reduce the blood volume. There are some now like the calcium channel blockers, which achieve the antihypertensive effect by relaxing the smooth muscles of the blood vessels. So usually there are some combination of drugs that we have here that they act concomitantly to achieve that antihypertensive effect. Now we have like the amlodipine and the temesirtan combination. Now when it is combined, the amlodipine works by relaxing the blood vessels, while as Ayo said, the temesirtan also also potentiates its effects by inhibiting the RAS, that is the renin angiotensin system.
In a nutshell, you're saying both of them have different mechanisms of action, but they are going to achieve the same goal. So it will potentiate the effect. Okay. Do you agree? Ayo, do you agree with what he said?
Yes.
So is that one? From Priscilla, is that one?
Any other contribution, question? If not, a round of applause for him. Mechanism of action of anti-diabetics, that is sulfonyl urate and berguanites, by Charles.
Is he ready for us?
Yes. Put our hands together.
What's the problem? You want to have a small shot?
Unit head. Good morning, my senior colleague. Good morning, intern, and good morning, my fellow colleagues. My name is Ada Charles, and I'm presenting on pharmacodynamics, pharmacokinetics, and mechanism of action of antidiabetics, that is sulfonylurea and bioagonists. So, I'll be defining antidiabetics. Antidiabetics are drugs. Antidiabetic drugs are medication used to control blood glucose level in patients with diabetes mellitus, especially type 2 diabetes. The two major oral classes include sulfonylurea and bioagonists, which is also called metformin. Pharmacodynamics of sulfonylurea: they stimulate insulin secretion from the beta cells of the pancreas. Also, they reduce blood glucose level by increasing insulin availability. Sulfonylurea also bind to sulfonylurea receptors to stimulate insulin release by closing adenosine triphosphate sensitive calcium channels on pancreatic beta cells, causing depolarization and calcium influx. The pharmacodynamics of bioagonists. Bioagonists do not stimulate insulin release, so no hypoglycemia. Also, bioagonists act mainly by increasing hepatic glucose production, also called gluconeogenesis. Also, it increases insulin sensitivity and enhance peripheral glucose uptake, especially in the muscles. Also, bioagonists delay intestinal absorption of glucose. So I'm also talking about the pharmacokinetics of sulfonylurea and bioagonists. Sulfonylurea is well absorbed orally. It is highly bound to plasma proteins. It is metabolized in the liver, excreted mainly through the kidneys. While bioagonist absorption is incompletely absorbed from the GIT, not bound to plasma protein, not metabolized, and eliminated unchanged in the urine. The mechanism of action of sulfonylurea and bioagonists. Sulfonylurea binds to sulfonylurea receptors on beta cell membrane. They block adenosine triphosphate sensitive calcium channels, leading to cell depolarization. Calcium influx triggers insulin secretion. Examples of sulfonylurea first generation example are tobutamide, while for second generation we have gliclazide and glimepiride. For bioagonists, it inhibits hepatic glucogenesis, leading to less glucose production by the liver. Also, it increases insulin sensitivities, which enhances glucose uptakes in the muscles. It also decreases intestinal absorption of glucose. Examples of such drugs are metformin, which is the only clinically used bioagonist. The adverse effects of sulfonylurea are hypoglycemia, nausea, and weight gain, while for bioagonists we have gastrointestinal upset and its metallic taste. Thank you.
Thank you for your presentation. It's kind of sketchy, but
Yeah. From Priscilla, please, can I say something? I think when we issued these questions to them, when we assigned these questions to you guys, we said you should do a PowerPoint presentation. This is not a PowerPoint presentation because I'm opening it with my PDF. I don't know, maybe I'm backward, I'm not in Gen Z Alpha this because I'm opening it with my PDF. It's supposed to be PowerPoint. So it means you disobeyed us. That's number one, disobedience. But Priscilla talked about character and learning. Abi? Yes. So character-wise, you disobeyed us. So Priscilla, continue.
are there any questions, contributions, comments?
You have a question?
You said the side effect of one of the drug is weight gain.
Yes. You want him to explain. So you want to explain how side effect of metformin, which is a bioagonist, causes weight gain, isn't it? Is it metformin now? Metformin causes weight loss, right? Metformin. Well, okay. We're asking you which one causes weight gain and which one causes weight loss. That's number one question. Then who has again? I have. Number two, you mentioned that in the mechanism of action of bioagonists, a delay intestinal absorption of glucose. What does this translate to mean? When there's a delayed intestinal absorption of glucose. So thank you. Do you have an additional question? So we have 2 questions for you. Need your attention.
Well, the decreased intestinal.
Answer his one first.
So you talk about the acts.
Are you dancing?
Yes. You can't just help her with this game.
Can anyone help him out? Rest of the
Yeah, I did. Don't try at all.
Do you want to help him out? It's based on the mechanism of action. Go back to your mechanism of action of sulfonylureas. You talked about that they are sensitive to potassium, calcium, leading to cell depolarization. So there will be influence of calcium and insulin secretion. Okay, the baguina, you said that it inhibits hepatic gluconeogenesis. So there's less glucose production by the liver. It's a bit sketchy. You didn't bring it out very well. Actually, it's from the mechanism of action. That's why for biguanide, that's metformin in particular, causes weight loss. And off-label, it is used as a means of reducing weight. It's one of the mechanisms of action. Go back to your books. I think for biguanide, it has about 4 major mechanisms of action. Then the sulfonylureas also is based on its mechanism of action, and that is why the primary reason why it's not really used as first choice of drug is because of its hypoglycemia. You understand? Even though metformin has that too, but it's not as much as sulfonylurea, how it will cause hypoglycemia and also causes weight gain. It's actually, there's a specific mechanism of action. Actually can't remember as well. Okay, so the next question. Or do anybody want to add to it? The next question.
So you talked about what?
Delay intestinal absorption of glucose. That is metformin in particular, baguanide.
Yes.
Or do you have another baguanide again? What example again?
Metformin is only clinically used baguanide because the other baguanides are toxic because of the lactic acidosis.
Even metformin still causes metabolic lactic acidosis. Do you know that? It still has, but it's just minimal compared to others. So continue.
So the decrease in intestinal absorption of glucose leads to the decrease in sugar level because when the intestines are not able to don't really absorb the glucose, it reduces the sugar level.
Can you tell me 2 basic side effects of metformin?
2 basic side effects. Gastrointestinal upset and
very good. So if you say gastric intestinal, metallic taste, not really. Hypoglycemia, that's number 1. Number 2 is the gastrointestinal. What do you think would have caused gastrointestinal side effects? Don't you think part of this mechanism of action, reducing the absorption, will also cause GI? One of it is diarrhea. Diarrhea is the most common side effect of metformin. I don't know if I'm communicating. Don't you think so? What I'm trying to tell you is that mechanism of action gives you the action of the drug as well as side effect. From there, you'll be able to detect the kind of side effects that will occur. Do you understand? So because when you go back to school, your pharmacology exam, once you have an understanding of the mechanism of action, you can deduce the possible side effect. If a drug is acting in the CNS, you should know that possible CNS side effect will come up. This drug is acting on the GI, is reducing absorption of glucose, which is beneficial, but at the same time, you'll be having GI side effects. That's what I want to establish. Thank you very much.
Okay, then I just checked that question on how sulfonylureas causes weight gain. They said it causes weight gain because it stimulates the pancreas to secrete more insulin, which promotes storage of glucose. I don't know if that makes sense.
Sorry, can you come again?
Sulfonylureas can cause weight gain because they stimulate the pancreas to secrete more insulin, which promotes the storage of glucose.
Yes, so if you're storing more glucose, of course, you know how it will relate. So there'll be more weight gain. While the other one actually depletes, it sensitizes the body, the cells to take up. That's the mechanism of action, is to take up glucose. So if you're taking up glucose, you're burning it, isn't it? So you actually lose weight. So thank you. Thank you from Priscilla. Please, can you go ahead?
You've answered the question.
Yes,
So I
next
think
presenter.
next presenter will be
My name is Trendy Pfizer and I'm presenting on pharmacodynamics and pharmacokinetics or proton pump inhibitors, including mechanism of action. So, introduction. Proton pump inhibitors are PPI. They are drugs that suppress gastric acid secretion by blocking the final step of acid production. They are also most effective drugs for acid-related disorder like peptic ulcer, gastroesophageal reflux disease, and Esolinger-Ellison syndrome. Common examples include omeprazole, esomeprazole, pantoprazole, lansoprazole, and rabeprazole. So the mechanism of action. PPI are prodrugs that become activated in the acidic panoply of gastric parietal cells. They are converted to active sulfonamide form, which binds irreversibly to cysteine residues of hydrogen, potassium triphosphates, and enzyme proton pump. This inhibits the final step of acid secretion effectively, stopping hydrogen ion release into the stomach. So the pharmacodynamics of PPI. Omeprazole and similar PPI starts acting within 1 to 2 hours after injection. Maximum effect occurs after 3 to 4 days of continuous use as pumps become inhibited. A single dose can suppress up to 90 to 98% of gastric acid secretion. The effect lasts longer than the plasma half-life because of irreversible enzyme inhibition. So the pharmacokinetics, absorption and distribution. PPIs are acid larvae, so they are formulated as enteric coated tablet or capsule to prevent destruction in the stomach. Absorption occurs in the small intestine and peak plasma level are reached within 2 to 3 hours. Food may slightly delay absorption but does not affect bowel availability. They are highly protein bound, about 95%. Continuation of the pharmacokinetics, metabolism and excretion. PPI like omeprazole, pantoprazole, and esomeprazole are extensively metabolized by cytochrome P2C19 and cytochrome P3A4. Their metabolites are inactive. The elimination of half-life is short, about 1 to 2 hours, but the acid suppression lasts 24 hours or more. Excretion occurs mainly through the urine as metabolites and partly in feces. The clinical use of PPIs: treatment of peptic ulcer disease, gastroesophageal reflux disease, Esolinger-Ellison syndrome, that's gastric secreting tumor. Prevention and treatment of NSAID-induced gastric ulcers, part of triple therapy of Helicobacter pylori eradication, e.g. omeprazole plus amoxicillin plus clarithromycin. Adverse effects of PPIs. They are generally well tolerated, but long-term use may lead to headache, nausea, diarrhea, or constipation. Vitamin B12 deficiency due to reduced gastric acidity. Hypomagnesemia, that's low magnesium with prolonged use, when the use of the PPI are prolonged. Increased risk of bone fracture and Clostridium deficit infection. Drug interactions. Omeprazole and esomeprazole inhibit cytochrome P2C19, reducing the activation of clopidogrel, an antiplatelet drug. And PPIs may alter absorption of drugs that require an acidic medium, e.g. ketoconazole, traconazole, iron salts.
Pantoprazole has the least potential for drug interaction among PPIs. So in summary, PPIs such as omeprazole, pantoprazole, and esomeprazole act by irreversibly inhibiting the proton pump hydrogen potassium triphosphate. They effectively reduce gastric acid secretion, making them useful in acid-related disorders. Despite their short plasma half-life, they provide long-lasting acid suppression. Proper use ensure maximum therapeutic benefit with minimal side effects.
Thank you.
No, you didn't say it, so we're waiting for you.
Are you done?
Yes. You didn't tell us thank you.
Thank you for this.
Thank you.
So that's why we're still waiting. If you just took the pause to say something.
Thank you for your presentation. It's not as if it's, let me say, Ayo, Anna, and things that have been attending presentations. People are not concluding. You're not giving summary. You got all the information from your brain, eh?
Yes. No reference.
We have to tell you the honest truth. So next time you ask to present, you know the right thing to do. So we don't have to pet you.
Go back to your slide is the standard.
For now.
For now. I don't know for now. So go back to, for those that are presented, go back to Ayo's slide. That's how the slide should be. That's how it should be.
And when you're giving a topic, you don't just bounce into the topic. Your introduction, at least, you're giving PPI because they want to talk about what? All the clinical uses, which is GIT effects, back disturbances like ulcer and all of that. You have to give us a brief introduction of what this condition is before you start. And it's most people do this. So let's just take the last presenter.
Okay, before I have observations, okay. Number one, your pronunciation. You should work on it. Because this is a learning ground. I'm actually not perfect, but I keep working on it and I'm still working on myself. You said nausea is nausea. You understand? These are not words that we manufacture, or it's not our tribal distance. Do you understand? So we have to learn. Then you also made mention of clopidogrel. You said clopidogrel. Antiplatelets. You said antiplatelet. There's what you call it. It's anti-platelet. That is even it's an anti-platelet. You understand? Then I want you to tell us. I know it was one that said we should be fast, but at least we should learn something from you. When a drug is being said that it has been metabolized through cytochrome P450 or cytochrome, other types of stereotype of cytochrome, what does that mean? That's number one. Number two, can you tell us on Zollinger-Ellison syndrome? What is it? Or do any of you know about Zollinger-Ellison? IT, Zollinger-Ellison? Is this the first time of hearing it, or you know it before now? So are you not curious? You don't want to know what that beautiful name is all about? Huh? So Pfizer, toothpaste. How are the last one? You said one of the adverse effects is B12 deficiency due to reduced gastric acidity. So I will be giving a lot of patients PPIs, omeprazole. In a day, how many patients do you dispense omeprazole to? Or any of the PPIs? Pfizer, how many patients do you give? Can't you estimate? In a day? In GOPD? I tend to disagree. Almost answer that question.
Let's say in percentage, let's say
yes.
70%.
Yes. What it implies is almost every prescription that comes into the dispensary, we give PPIs. And now you're telling us that there's B12 deficiency. So when does B12 deficiency comes? For how long will you be taking PPI the B12 deficiency comes? For 3, because it's very important. So 3 questions. Thank you.
But the cytochrome P450 is taken from a group of liver enzyme.
Remove your hand from your foot.
They break down this drug like omeprazole, esomeprazole, and
only those drugs?
No, more.
What I'm trying to establish, when you hear a drug is being, I don't know if you get my question. Do you get my question? When a drug is being metabolized by cytochrome P450 or any type of drug, what comes to mind? What does it tell you? Drug interaction. Do you understand? It means that this drug, there are other drugs too that will be metabolized by these enzymes. So it's either it will increase, induce it, or reduce it. You understand? So you should know that this drug is likely to interact with other drugs. And when you're counseling your patient, you should be able to tell them that you should not take this drug at so time. You understand? We all know that food interact with PPIs. Other drugs to interact with PPIs. So we don't. When we are dispensing, you watch us, you hear us counsel the patient and tell them take after 30 minutes before food, or 30 minutes after food, or 30 minutes before your medication. At least 30 minutes. We used to say that. That's the reason why we're saying that. I want to, as I said, I want to show you the relationship or the correlation between theory and practical. It's not just reading. We apply these things. And your second question.
Vitamin B12.
So that was not the second question. The second question I asked Zolinga Ellison is a very lovely name, so we want to know what it's all about. Are you ready for us? You want a lifeline? What you call a lifeline? You have lifelines here, and you have the resident and also the interns as your lifelines.
I think the condition where medical produce more acid.
As a result of what?
As a result of...
Because if I have dyspepsia, there's acid production. If I have GERD, like you said, or GERD, there's acid secretion. You understand? Each condition have a unique, there's something we call differential diagnosis. They all have unique features. So for Zolinga Ellison, what is it?
I think because of a tumor.
Yes! There's a tumor. There's a tumor. That's what is called Zolinga Ellison. So it causes more acid secretion. Tumor we know is an abnormal cell, abnormal growth. So there's an abnormal production of acid. That's why it's being used. There's something called gastritis too. It's also very common. That's why you see prescriptions that we refill for patients with gastritis, ulcer, either peptic or gastric. There's gastric, like that, and also the GERD. That's why you see domperidone because of that reflux. Okay, then the last one.
The vitamin B12 deficiency. I think because the body also produces vitamin B12 and PPIs also produce vitamin B12.
Yeah, is that what it is? This is a new research. Do you agree? Kingsley, do you agree? Can you explain?
Personally, I don't think proton pump inhibitors they produce, because the main mechanism of action for proton pump inhibitors is preventing the secretion of acid. So usually the body, yes, it does produce B12 in minute quantities. That's why sometimes supplements are prescribed to make up for the lacking.
The question I'm asking, why I brought this to our attention is counseling. Does that mean whenever we're giving PPIs, we should also give vitamin B12? Or when do we give vitamin B12? That is my question. I'm showing to the house. We might not have the answer now, but if we do, let's communicate to the house. I don't know if you got that. Okay, the question is, PPIs causes vitamin B12 deficiency. So meaning that if you're taking PPIs, there's a likelihood that you have vitamin B12 deficiency. So in essence, you should give supplement with vitamin B12. That's what it means. But now, does that mean that if I'm going to take PPI for a week, will I get vitamin B12 deficiency? So we have to probe, we have to ask questions. That's what I'm trying to say. Yes, ideally we're supposed to give vitamin B12, but there are signs of vitamin B12. Do you understand? There are signs, so we ask questions. I don't know if there are laboratory tests that we do to show that there's a deficiency. Do you understand? So I'm throwing to the house because this is food for thought. This is food for thought. Thank you.
Okay, let me say, because the proton pump inhibitors reduces acid secretion, right, in the stomach, and acid secretion is needed to synthesize B12. So that way, if the secretion is reduced, so there will not be enough acid to synthesize B12. That's why it is reduction of B12.
I agree with what I'm saying is now, we already established the B12 deficiency. So you should supplement with B12, right? That is what it means, literally, right? So now if I'm to take
how long? Okay, for how long?
yes, if I'm to take omeprazole for 1 week, does that mean I need to take it along with vitamin B12? Let me give an example like nitrofurantoin. You know, nitrofurantoin works, it's best absorbed in acidic medium. So when we are dispensing nitrofurantoin, we dispense it along with vitamin C so that you can achieve the maximum optimal benefits and effects of that particular drug. So are we going to do same with PPI? When we are giving PPI, we should give B complex? That is my question, and it's food for thought. Thank you. Next presenter. You know, you don't volume. We don't want bedroom voice. Volume.
Our senior colleagues, our residents, and my fellow colleagues, I'm talking about the pharmacodynamics, mechanism of action, and pharmacokinetics of antibiotics. I'll start off by defining what an antibiotic is. An antibiotic is a chemical or drug that fights bacterial infection in humans or animals. It works by either killing the bacteria or by inhibiting the growth of the bacteria. Okay. When it kills the bacteria directly, it's called bactericidal antibiotic. If it inhibits the growth of the bacteria, it's called a bacteriostatic antibiotic. I'll go on to the pharmacodynamics of antibiotics. Pharmacodynamics refers to what the drug does to the body or the bacteria of the body. Antibiotics exert their effects through two main ways. The effect of antibiotics on bacteria depends on two ways. The concentration of the drug at the infection site, or the duration of exposure of the bacteria to the drug. When it's dependent on the concentration of the drug at the infection site, it's called concentration dependent effect. Examples of drugs that have these effects are gentamicin and ciprofloxacin. In this case, the extent of bacterial killing is dependent on the peak concentration of the drug at a certain period. So the higher the concentration, or the higher the peak plasma level, the more effect it will have at killing the bacteria. So for this type of antibiotics, you require less frequent dosage. So you can give them once daily. An example would be gentamicin. Gentamicin is usually taken once daily, but if we break it into smaller doses and give them at intervals, it doesn't have the same effect as one injection that's taken once daily. The time-dependent effect. Examples of drugs with these effects are penicillin and erythromycin. Bacterial killings in this time-dependent effect depends on how long the antibiotic can remain above the minimum inhibitory zone. The duration and not the concentration matters. No extra effect happens with increased doses. Example would be penicillin is given as an infusion because penicillin is usually given as an infusion because it doesn't have an effect if it doesn't remain above that minimum inhibitory zone. It has to remain above that zone for a long period of time for its effects to happen. Then I'll move on to the mechanism of action of antibiotics. Antibiotics have four main mechanisms of actions. The first being cell wall inhibition, cell wall synthesis inhibition, protein synthesis inhibition, nucleic acid synthesis inhibition, and metabolic pathway inhibition. The cell wall synthesis inhibition, antibiotics with these effects are penicillin and vancomycin. These antibiotics inhibit the synthesis of peptidoglycan, which weakens the cell wall and leads to cell lysis, which leads to cell death. Inhibition of protein synthesis. Examples of such antibiotics are tetracycline and chloramphenicol. These antibiotics bind to the 50S and 30S ribosomal subunits, blocking protein formation and ribosome transcription. Without protein synthesis in bacteria, they can't divide or grow, so to lead to their death. Inhibition of nucleic acid synthesis. Examples of such drugs would be levofloxacin and metronidazole. They work by inhibiting DNA replication and transcription and preventing the multiplication of bacteria. The fourth mechanism of action is inhibition of the metabolic pathways. An example of such drug is sulfonamide. It works by blocking folic acid synthesis in bacteria, and in the process it starves the bacteria of essential nutrients, making it easier for the immune system to fight against the bacteria and end up killing them. Moving on to the pharmacokinetics of antibiotics. Pharmacokinetics refers to what the body does to the drug. There are three main stages of pharmacokinetics: absorption, distribution, metabolism, and excretion. In absorption, for antibiotics, the oral route is the most used route. It allows for absorption of the drug through the GIT and into the bloodstream. Example of such drugs is amoxicillin and doxycycline. For parenteral routes, it allows for complete absorption of the drug. It's used for drugs that are poorly soluble when given orally. Examples of such drugs are gentamicin and vancomycin. Then the topical route of administration is used for drugs that, for bacteria that can only be killed by localized effects on the skin or mucosal layer. Example of such drugs is neomycin. Factors that affect absorption are food interaction, drug interaction, gastrointestinal pH, GI motility, and drug formulation. For drug interaction, antacids, when taken with most antibiotics, reduces the absorption of the antibiotics. For food interaction, doxycycline, when taken with milk or any food that has calcium, reduces the absorption of doxycycline. Gastrointestinal pH, erythromycin is acid labour, so it's easily destroyed by stomach acid. Hence why it has enteric coating to prevent it from being destroyed by the stomach acid. Moving on to the distribution, there are two main factors that affect the distribution of drugs through the system: lipid solubility and protein binding. Lipophilic antibiotics penetrate through the tissue easier, and hydrophilic antibiotics do not penetrate through the tissue easily. Protein binding. Only drugs that have pharmacological effects are free in the system. The ones that are bound to the system have no pharmacological effect. Ceftriaxone is 85 to 95% bound to plasma, which means it has a longer half-life and needs lower dosing. Amoxicillin is 20% bound to the plasma protein, which means it has a shorter half-life and requires multiple doses in a day. Metabolism. Antibiotics are metabolized minimally, and some are metabolized by the liver, while some are inactive, and when metabolized they become active. For excretion, there are two main excretory organs in antibiotics: the kidney and the bowel and the feces. Thank you for listening.
Now, are you finished?
Yes, ma'am.
Thank you for your presentation. Antibiotics is very broad. I saw many of you taking selfie. If you go start pharmacology, like 50% of what you'll be taught is antibiotics because it's broad. It's broad. So on your own.
During the presentation,
yes,
you have passed.
So please,
We'll give them extension. This will not be their last video. Come back next week.
you know NHIS is looking for something to keep you here.
Yes,
So
but
you
those
better
that identify them, we'll give them next.
all of them, let all of them serve the punishment if they will be. Because you saw them and you didn't want them to stop.
I was focused on
You were focused. it's not nice. Even if I know you also contributed because you didn't carry us along, you're practically talking to yourself,
Yes.
which is not good. You have to work on your it's your weak point. Work on it.
If not, while you are presenting, people not looking at your slide if you have, and you will not.
They will even sleep.
They will sleep.
The truth of the matter is that your presentation skills determine how the audience will respond. Do you understand? The way you're talking sincerely, I got discouraged. And something that's very interesting. The only time that you caught my attention, because I was waiting for you to finish and let me attack you, but you did something that impressed me. When you were talking about factors that affect this thing, he narrowed it down, he made it practical. He will say doxycycline, he will give example of absorption, he will give example of excretion. That was why what silence do. If not, I was ready for it. Sincerely. But talking to yourself, we're here to learn. Eh? No lecturer, is there a lecturer that talks like this in school? The student will not learn. Or you say, I know you're a gentleman, but when it comes to learning, I don't want to say ras, but at least be, yes. Do you understand? I'm not saying you should do IELTS way. IELTS is a bit on the extreme. Just be moderate. Do you understand? And then,
Then you know 500 level you're going to do projects and you do your project first and then presentation then. All those things have marks.
and during internship again,
You still present. So you have to
have you not been attending internship and intense presentation?
work on that.
Please.
When you are coming, you always have your microphone with you.
Then you bring a speaker and people. So you see, to cost you more. Please work on yourself.
Work on that and then I think basically everyone has tried as much as you can.
I still have questions for you. Yes. You made mention of gentamicin. That gentamicin can be taken, if taken is once daily. If taken in small bits, smaller doses, and you will not achieve, you will not have the same effect. So I want to ask, like, because I'm trying to understand, you're talking about antibiotics, I don't know if it's just gentamicin. Amoxicillin can be taken BD, TDS, even QDS, depending on the disease condition. Amoxicillin clavulanic can be taken BD, can be taken TDS as well. So why is that? Do you understand? I want to understand. I did the same. Is it concentration effect or is half-life effect? I don't understand. That's my number one question. Then okay, that's the question I have.
This delivers a short half-life. So once it's in the system, it easily gets depleted from the plasma
Metabolized.
protein.
Let's use the word
Metabolized
metabolized.
from the plasma protein. So it needs to be administered in multiple doses. You said sometimes it's given 4 times a day. It depends on the severity of the bacterial infection. So for high severity, they'll give it more times daily to achieve.
So now what you're trying to say in essence is that for amoxicillin example that I gave has to do with the half-life, but not the concentration now. There are two things. The gentamicin is now more of the concentration.
Yes,
Because I know gentamicin, they used to give BD, 80 milligram ahead. We have 80 milligram daily sometimes. You can take TDS, you can take BD.
Amoxicillin is time dependent, not concentration dependent. So it has to remain.
But the example you gave was under concentration.
Yes, I gave an example of gentamicin, and gentamicin is concentration dependent. It's only given once daily, but if it's given in smaller doses multiple times a day, it won't be effective. But since amoxicillin is time dependent, you have to give it multiple times in a day to maintain the level.
I think you should work on it. That's what I want to extend. But practically, gentamicin can be given. The question is the maximum daily dose. You understand? He said concentration dependent. It's the maximum daily dose. Do you understand? What's the maximum daily dose for that particular indication you're managing?
Okay, but let me think, can be repeated.
Yes, it can be repeated.
Because I know practically it can be repeated.
It can be repeated. It can be taken 80. What he's just trying to give an example. Of course, those that are concentration dependent, and then the time he meant is half-life. It's half-life, not 7 a.m., 10 a.m. timing. It's the half-life. Isn't it?
There's one question I want to ask.
Okay, please go
about penicillin. He said it can only be given intravenously.
I said.
So something you said about penicillin.
I gave penicillin as an example.
You don't need to go
Not
at
even
your screen.
as
It's not even a slide, it's
not
PDF as well.
Penicillin V.
Give penicillin
is
V.
no, there are different types of penicillin, but I just said penicillin. Penicillin V can be taken orally. Okay.
I want you to go back to that slide.
Don't worry. We'll get there. Continue.
Penicillin V can be taken orally. That means not acid level. Or penicillin V.
You said V is oral. That's what you said.
Sorry, penicillin G is taken with injection.
Penicillin G, don't we have the oral? This penicillin G.
Is it crystalline penicillin?
Penicillin G is oral because I just ordered penicillin G. V there's oral. What of G? G there's oral too now.
Which one is benzyl penicillin? Which one is crystalline
Basically, those one are the IV.
Please go back to that slide. Read that slide again. You seem to be generalizing penicillins as can make only.
Okay, what I want to ask is amoxicillin a penicillin? Don't worry. Is amoxicillin a penicillin? Is ampicillin a penicillin? Is cephalosporin and this one cephalosporin? Yeah. Is cephalosporin a penicillin? Tell her I'm in this thing. I can't answer her.
She said it's past 10.
Benzyl penicillin G is benzyl penicillin.
Sorry,
And yeah.
So benzyl penicillin.
We're talking. We're recording. I'm talking. Yes, we're attending to them. Are we not attending to them? Do you understand? Penicillin G is injectable.
It's injectable.
It's injectable. What is this? What she's trying to tell you? You did not establish your facts well.
On that time, I gave an example of penicillin. I won't say penicillin.
And that is the amoxicillin you just elaborately explained. Do you understand? But you didn't understand not until her question. It's her question that made you to understand. When you were explaining, you didn't know that this was what you were saying. So penicillin is just like a family name. There are other yes.
Most of them are other things.
So from Priscilla.
Okay. All of you have done well. Shows you went and did your homework. Please gather those presentations, read them, study them. When you enter 400 level, pharmacology will be more serious. The pharmacology is that one that had bulky material. 400 level. Yeah. You will see material up to 22.
It's very tedious.
It's tedious. So this presentation you've done now, if you do it very well, you would have studied like 60%, I'm not mistaken, of what you do in pharmacology 400 level.
Yes.
So don't take it lightly. Study them very well and do more. Wish you all the best. Well done.
Yeah.
Do you have any questions to answer later?
No question to answer. This is their last week. I just want to appreciate, on behalf of my colleagues, to appreciate all the IT students. You guys have demonstrated diligence. You have demonstrated competency. You have demonstrated, even though some are not punctual, don't come punctual. I don't want to mention names, they know themselves. Yes, they should correct themselves because lecture starts by 8. The person knows himself. He's looking at me, he knows himself. Charles was born in this. Because he knows himself. You should learn. You're supposed to report 8 a.m. The lecture time is 8 a.m. This translate that discipline translates to your when you just start working. It translates to your punctuality. This is just the beginning. Our doors are open at any time. You can always come to us so that we will guide you. We encourage mentor-mentee relationship. Take us as your mentors, and we'll also take you all as our mentee. I believe each one of you, the residents, are willing at any time. They can send you messages while they go back to school because this is their last week. While they go back to school, they can always call on us to assist them in any way possible. Does that include financial way? Yes. Thank you. So that's all.
Does anybody have anything to say?
Yes, maybe a farewell.
Yes,
something to tell us to do better.
Yes, they have to go.
Thank you so much, Ma.
Ma, first I would like to appreciate you for.
Only me?
No, Ma, I'm sorry to that. I would like to appreciate you for how you took us. Like when I came here, I didn't feel like I knew anything to actually work at a pharmacist because I practically did not know any name of any drugs, just the common paracetamol. But when you took us under your wing, you were patient with us and we were ready to guide us even when you were busy with your own personal work and your own responsibilities. So I want to especially appreciate you on behalf of the IT students of both NHIS and Uniabuja. Then I also want to give a special appreciation to our residents, pharmacists, and also our interns in the absence of from Dakuru and from Diki, from Yunusa and from Adamu. So because they have been so helpful in terms of counseling, in terms of guiding us and helping us correct our mistakes, even when we did not do so well. So I also want to especially appreciate from Priscilla that always took her time to educate us on and improve our knowledge on several classes of drugs, even when she was busy. So I want to thank you all, and I hope even as we live here, even as we try to make the pharmacy brand proud, I hope we also make it proud to wherever we go. So thank you, ma'am, and thank you, everyone.
Any from GOPD? Any feedback from GOPD? Anybody? Okay. Thank you.
Thank you so much. Tell you your confidence. Confidence can save you a whole lot of stress. Don't be confident in talking rubbish. But even the little you know, be confident about it. You can even confuse your lecturers, especially when it comes to all these dispensing, presentations and all. Work on your confidence. Okay? Nothing is too difficult, nothing is impossible. People have done it before, so you too can do it. We went through the same process you went through right now, so it's doable. Huh? So take that to heart and we should see you very soon for your internship.
For those that was very hard on, it's part of the training. I believe being hard on you will bring out the best in you. That is my policy.
So we're going to have 2 salaries. So one for invoice and one for...
I think when we're done.
Back to work, everybody.
Are you sure?
Yes, sir. I told her you are not at the nurse.
So now,